Hello, everyone. Thanks for joining us for today's episode of CHS Presents Health Connect. I'm Jane Hansen, along with my co-host, Dr. Patrick M. O'Shaughnessy, Catholic Health Services Senior Vice President of Medical Affairs and Chief Medical Officer. As part of Catholic Health Services of Long Island's focus on quality of care throughout the entire system, performance improvement teams across all disciplines aim to provide every patient with the very best care possible. And Dr. O, that's got to be hard with 17,000 employees and 6 hospitals and all kinds of clinics and ambulatory services and et cetera, et cetera, et cetera. How do you do that?
It is really a journey, and that's really what today's show is about, is that, CHS is on a continuous quality journey using high reliability as the chassis for everything we're going to speak to and everything that we're working on. And to your point, Jane, some of the things that we do in our organizations, they're very complex, whether it be a coronary artery bypass graft or total joint replacement. So our patients and their families come to us because they want to be helped. The last thing that we want to do is harm them. And reducing preventable harm events is still the greatest opportunity in all of healthcare, not unique to CHS, but CHS has taken a very strong approach to reduce these events and get them down to zero.
Exactly what do you mean by preventable health events?
So as an example, there are a whole host of conditions that patients could unfortunately run into when they're seeking healthcare services in any healthcare facility in the world, such as an example, a surgical site infection or a hospital-associated infection. And these are the events that when we speak to continuous quality improvement, we're building strong processes in place to eliminate these events from happening in our facilities.
But how do they happen?
So many times they can happen because of a failure of care. Many times it's because of even no failure on an employee or staff member, but more in fact because of just the complexity of the work that we're doing. Mm-hmm. Sometimes people can have a complication. So you want to be able to recognize these earlier, prevent the ones that you can, catch the ones that do occur that are unpreventable, mitigate them, trap them before they become bigger problems. That's the essence of high reliability.
Okay, so you have these people that are performance specialists, for lack of another word. So they come in and their job is to really take a look at day-to-day events.
Yes.
And how does that work?
So it's very complex, but there's a science behind it. And in fact, Dr. Avidis Donabedian, one of the founding fathers of quality, really set the framework for this, which is structure, process, and outcome. So many times people in healthcare systems will focus on the outcome measure, the rate of infection, the rate of readmission, or whatever the parameter may be. But if you don't start with building the appropriate structure of teams to look at that problem and then develop processes, and where they may not be working so well, develop what we call robust process improvement, to make the outcomes better. These teams, these quality teams, James, what they do is they analyze data and they help build these processes to make care safer.
How do you make sure that those new things you're doing, those new initiatives are going to have the same high quality?
Yeah, it's an excellent question. So you build off of some of your past successes. And as an example, one thing that is very clear is that centers and provider teams that do the most of a set procedure generally will have the best outcome. And this is why care in our system is shifting into destination centers. And as you'll hear from folks at St. Francis, who have led not just on cardiovascular care and developed an international reputation, and as those new programs develop, you'll see the same processes in place for an interventional procedure that's new that were in place for a surgical procedure. They take that same if you will, algorithm, and they will apply it to another service line. And many folks think of only St. Francis as an example as the heart center, but they've done over 1,000, 1,100 total joint replacements in orthopedics. They're an orthopedics, if you will, center of excellence. Sure. The oncology program has done incredible work in providing systemized, integrated care that's of exceptional high quality. And our other guests today at St. Catherine's have really led on some of their incredible work for sepsis, which is really a systemic blood infection that they've been able to recognize patients earlier, treat them more aggressively, and provide better outcomes.
Wow, well, you've really laid it all out for us. So let's get to the show.
Okay.
We're going to discuss this continuous quality journey with two representatives from St. Francis, Dr. Ronald Gullotta, the Vice President of Medical Affairs and Chief Medical Officer, and Anna Baracchini, the Assistant Vice President for Performance Improvement, as well as two representatives from St. Catherine of Siena Medical Center, Dr. Jason Golbin, Vice President of Medical Affairs and Chief Medical Officer, and Laura Uditsky, Director of Performance Improvement and Quality, about how these two CHS hospitals and all of the CHS hospitals are constantly striving to improve and provide the best possible care to the communities they serve. Stay tuned. We'll be right back with today's episode of CHS Presents Health Connect. Hello and welcome back to today's episode of CHS Presents Health Connect. For decades, Long Islanders have depended on and turned to St. Francis Hospital, the Heart Center, as a world-class medical institution offering the safest, most caring, most compassionate, and most comprehensive care on Long Island. While recognized as a leader in patient-centered care, the hospital doesn't stop there, instead continuing to focus on all aspects of performance improvement.
Joining us today is Dr. Ronald Gullotta, the Vice President of Medical Affairs and Chief Medical Officer at St. Francis Hospital, the Heart Center, and Anna Baracchini, the Assistant Vice President of Performance Improvement at St. Francis Hospital, the Heart Center.
Welcome. Good to have you here.
Thank you.
Thank you.
So let's talk about this. So St. Francis, known as the Health Center, the Heart Center, really is a lot more than the Heart Center.
Yes, interesting. St. Francis has its roots going back into the 1950s, where it was originally a sanitarium for children who had rheumatic heart disease. And back in the early 1950s, there was quite a bit of rheumatic fever, which translated into what we would call rheumatic heart disease. And some of these children would come to St. Francis where they would try to recuperate. Over the years, it evolved into an acute care hospital. And then over the past 30 to 40 years, it really took hold as a cardiac center because of its original roots with rheumatic heart disease. And it has grown into an internationally renowned heart center. Over the years as well, because of the excellent care that the hospital has given to these cardiac patients, well, we've seen some of these patients live longer. And as a result, they're coming back to the hospital now, not necessarily with cardiac problems, but now with other chronic illnesses.
Like?
Well, for instance, we see quite a few patients now with orthopedic problems. And in addition, unfortunately, patients that are now surviving their acute heart attacks and their heart failure and having surgery and other corrective modalities for their heart disease are coming in with some chronic illnesses like cancers.
And so you're treating those as well, and you're wanting to make sure that the consistent good care that you've had for the heart extends to everything else.
Correct. So what we've done is the processes that we've developed for cardiac patients, which really over the years have been honed, and to say the institution is run like a well-oiled machine is really not even doing it justice. The volume of cases continues to be exceptionally high, and that volume has translated into excellent practices. The nurses have cardiac care down to a science. The cardiac patients that come out of the ORs are well managed. They're basically the throughput is rapid and the outcomes generally excellent. So what we've tried to do is basically to take those same processes that we found were so effective with the cardiac patients and translate that into treating patients with, for instance, orthopedic problems and cancers.
So Anna, it's your job to make sure that everybody's following these same standards.
Yes, over the years what we try to do is to analyze our processes and make sure that we have a robust process improvement program at the hospital. And that's looking at each of the processes that are in place, making sure that they're standardized, that they work the same way each time you implement them, and the outcomes are consistently good. And every once in a while you have to go back and change it or tweak it depending on how the modalities of care are changing, but it's still essentially the same concepts that you would apply to all the same to the programs. For example, we try to look ahead and prepare patients for their encounter at the hospital. So with the total joint population, the hospital has created what they call the peri-op surgical home. It is a collaborative amongst the surgeons, physicians, anesthesiologists, our nurses, our mid-level practitioners, PAs, and nurse practitioners. And what they're starting to do is to prepare the patient prior to coming into the hospital with the expectations of what they can possibly anticipate and better prepare them for that surgery. And we've resulted in, our early data has shown that we have decreased our readmissions, we have decreased our length of stay, we've decreased infections, and we've increased patient satisfaction. So it seems to be good.
Yeah, just by prepping them in front?
Yes.
And so they know exactly what to do when they get home?
Correct.
Oh,
And
that's interesting.
We've applied that same principle to the general surgery population for colon with an enhanced recovery protocol, and their select patients would be prepared again in the physician's office. This is what you can anticipate. This is how you should prepare for surgery. This is what should happen on day 1, day 2, and so forth. And it seems to be working very well, and we've had the same success.
So they're following your instructions. They're being good patients.
They are. We give them printed material. We use evidence-based practice, the best that the literature has to offer, and we break it down into terms that the patients can understand and why it's important for them to follow. Because you can tell patients, but if they don't follow it, it doesn't work. So you have to be able to sense the patient's ability to comprehend the information that's given, make sure they adhere to it, and give them the support that they need, knowing that they're going to face this surgery.
You know, I'm wondering, Dr. O, with all the focus now on getting people out of a hospital quicker and maybe having ambulatory surgery, they can go home the same day, that sort of thing. Does that make the quality control even harder?
Well, it's interesting that you bring that up, because when you look from a risk perspective or a quality perspective, the risk is actually higher in the ambulatory section, because traditionally those ambulatory platforms did not have the aspects that Anna just spoke to in place. Our approach is to take the same approach. It doesn't matter if you're in an ambulatory surgery center or you're in the hospital. It's the same protocols, it's the same processes, it's the same adherence to quality and safety. And then we look to also make sure that the processes are efficient, and so that everybody is aligned. I think one of the things that Anna spoke to is that it's a multidisciplinary team. The surgeons, in fact, are a very integral part of it, but there's so many other people, like Anna mentioned, that they all play a role in this to provide that best outcome for the patient.
And what about the price tag associated with this kind of, this real quality control?
Well, let me comment, if I may. Actually, for all the things that Dr. Galata and Anna mentioned, you actually have less cost per care when you look at the total episode of care. Why? Because you're reducing complications of care, which add cost. You're reducing length of stay in the facility, which reduces cost. And if all goes well, you're reducing a potentially preventable readmission, which could add further cost.
You've got something that you've just added at St. Francis. I want to make sure I pronounce this correctly, the transcatheter aortic valve replacement. Now, and that's a whole new area for you. So how do you go about implementing something new and make sure that, again, it's really at the highest quality standards?
Sure. So this new procedure is called, you may hear it referred to as TAVR, which is T-A-V-R. It stands for transcatheter aortic valve replacement. Now, traditionally, patients who develop aortic valve disease, usually it's what we call aortic stenosis, which is a narrowing of the valve. Those patients have been treated surgically, because medical therapy is ineffective. And what we've done now is we've taken a population of elderly patients who have severe aortic stenosis, who are very symptomatic, who have been deemed too high risk for surgery and therefore basically not treatable, and offered them a more or let's say less invasive alternative. And this is done through percutaneous methods, which is similar to what we do with cardiac catheterization. People may have heard of these angiograms and balloon and angioplasties and stents that we do, where the tube goes in through the leg. And we've adapted these techniques to now deliver valves directly into the heart. So what we've done now with, for instance, at St. Francis, when we rolled out this program, about a year and a half prior to the first patient being treated, we assembled a team, again, like Patrick was saying, it's a multidisciplinary team. We had cardiac surgeons, interventional cardiologists, mid-level practitioners, anesthesiologists, nurses, and what we've done is we sent them to Minnesota, where they received some training from industry as to just working with the mechanics of the new devices in terms of the deployment of the valves, because it was all new technology, so just to get up to speed with the technology. So they went to industry where they learned how to use the devices, almost like laboratory type things. Once they became familiar with those processes, then they were then sent to hospitals where it was actually being done, and this team observed other teams in action so that it was basically learned by doing and by observing. Once they received adequate training, we brought them back to the hospital and then set up to do the first patient at St. Francis, which was about 4 years ago. The same processes that we had honed and perfected with the cardiac surgical patients were now being applied to these TAVR patients, where we, again, had the team approach in terms of a whole cohort of doctors, nurses, mid-level practitioners, all working toward the same goal. And the quality measures that we were applying to the cardiac surgical patients were applied to these patients as well.
Well, that sounds really interesting. Real quickly, can you tell me about Project Red Card? Because I see that on my notes.
Okay. Well, we found that there's a big sepsis initiative is a big focus throughout the state and the nation now. New York State being the leader by having a sepsis registry where every patient that's suspected of having sepsis, which is an infection and a huge inflammatory response, and with a high mortality and morbidity. We joined that program, and we also built up our cancer program. And we found that our patients who are on chemotherapy are very sensitive and at very high risk to develop infections, but their symptoms may not be the same as a person that's not on chemotherapy, so they have different presentations. So we've identified, the nurses actually in the infusion center actually identified to build a red card, and on it, it tells the patient what to look out for, and then to present this card when they go to an emergency department, so that the emergency department can identify right away that this patient is at risk and their labs or their presentation may not be what they're looking for to identify sepsis, so they have a heads up. Be certain that you're looking for sepsis so that you can treat this patient, because there's a small window of time that you can start treatment and have a successful outcome.
So it's about having great communication and understanding exactly what's going on with that particular patient. That sounds like a really great idea. Thank you both so much for being with us. We really appreciate it. And we have to take a quick break. We'll be right back. Welcome back to CHS Presents Health Connect. With us today as we continue our discussion is Dr. Jason Goldman, Vice President of Medical Affairs and Chief Medical Officer for St. Catherine of Siena Medical Center, and Laura Uditsky, Director of Performance Improvement and Quality, also at St. Catherine of Siena Medical Center. Welcome. Good to have both of you here.
Thank you very much.
Thank you for having us.
So we're really talking about sepsis today, that infection that can cause all kinds of problems in the hospital.
So sepsis is actually a syndrome in which an infection sets off an inflammatory response in the body, which leads to a cascade of actions. Now, mild sepsis may present with simple vital sign abnormalities, such as you're breathing fast, or your heart rate is fast, or you have a high fever. The problem is, as that cascades through the body, it starts to affect the organs of the body, such as the lungs, in which case it becomes hard to breathe, and you develop respiratory failure. The heart, where it doesn't pump as well, and the heart can fail, and you have heart failure. The kidneys, where you lose the ability to urinate. Once that happens, the severity increases to the point that the name changes to severe sepsis, signifying the critical nature of that disease. The goal is then to grasp that and control that before it becomes even worse. And what's worse is something called septic shock, which is a state in which the body's blood pressure drops despite all the treatment we're administering. The problem is the mortality, the death rate, the chance of dying with septic shock is up to 50%.
Whoa. No matter what you can do at that point.
It's an interesting question. So sometimes we can intervene and make a change, but many times we can't. And that is why we're working so aggressively to fix this problem.
But is sepsis really something that's much more susceptible in a hospital or outside of a hospital? I mean, I guess I'm wondering why the complete focus on it.
So many patients present to the hospital with a mix of symptoms. They just don't feel right. They're breathing a little fast. And our goal as a hospital is to recognize that actually what's going on is the sepsis syndrome. And then once we recognize it, we can start the treatments that have been proven to then reduce the chance of dying from that disease.
Is it mostly medication, or what is it, the treatment?
Well,
First and foremost, as Dr. Goldman mentioned, is the early recognition. And at St. Catherine's and CHS, we've utilized our electronic medical record and technologies to allow for prompts. So when patients come in, nurses are screening these patients and do a sepsis screen, which looks at the vital signs, look at their symptoms that they come in with, looks at their risk factors, such as are they immunocompromised, are they having uncontrolled blood pressure. This prompt, if they screen positive, actually goes right to the physician. And when they go to see the patient, they determine, is there a suspected infection? If they evaluate the patient, say, yes, there is a suspected infection, we may not know exactly what it is at this moment, we need to start our bundles of care. So the first thing we do is they order a panel of orders looking at lactic acid, which is an indicator of hypoperfusion of oxygen and nutrients throughout the body. They order blood cultures and a broad spectrum antibiotic. Like I mentioned, they may not know what the infection is, so they want to get an antibiotic that covers everything at this point while they further evaluate. They order, they look at source control. What could be the infection? Is it urinary related? Is it pulmonary related, such as pneumonia? And they wait for some results to come back. As these results come back, we talk about our bundles. We're looking at that lactic acid. Is the patient in a state of a little bit of organ failure? That Dr. Goldman mentioned is severe sepsis. So then we need to give those antibiotics within a 1 hour window. We need to look at, you want to give antibiotics
1 hour?
Very quick.
Correct, yes.
It's a challenge, but you want to get them in. The earlier you get them in, it relates to earlier, better chances for survival.
There's clear data to demonstrate that with each hour delay, the chance of dying increases.
Whoa, so this is it's an extraordinarily scary phenomenon, but I guess the focus is because is this something that in many cases in the past would have been missed? I guess that's what I'm trying to figure out why this real focus on it.
We've been looking at sepsis for many years. I'm a critical care doctor by trade. And for 30 years, we've been aware of this syndrome of sepsis, but we never had anything that worked to decrease the mortality. In 2001, the data started piling up that if we recognize the patients early and start the treatment, including antibiotics, fluid, and appropriate management and resuscitation, those patients will do better. But it wasn't until 2001 that we had that data. So as that information has percolated out through the medical community, we've been able to really start making progress. Now, we often don't know what infection. It can be the lungs, it can be the urinary tract, it can be in the belly. But we administer a broad spectrum, wide covering antibiotic, and then as we learn more, we start to narrow the focus.
Sure, but you've got to get that first big
Correct.
dose in immediately in
And
order to save the patient. You keep talking, Lori, about bundles of care. I know this is something that's a really important to you.
So just for the folks at home, many of the folks may think of bundling when they look at insurance coverage or perhaps their cable and telephone coverage. You're grouping things together for better value. Well, by grouping these interventions together with early recognition, as Dr. Goldman and Lori spoke to, their additive focus gives a better outcome. So that's the focus of what we're trying to do. So that's why there is a sepsis bundle. You'll hear in other areas a colon bundle. A series of interventions, when performed together in the right sequence and time frame, will afford the patient the best outcome. But I can't stress enough what these two folks have mentioned. The early recognition is really key. And I wish, this started to come into real fruition as I was a practicing emergency physician. You could spend an hour or 2 hours trying to work through what's going on with the patient. But now, with some of the heightened education and awareness of subtle signs of sepsis, as Dr. Goldman mentioned, and the clinical decision support to prompt me, so I might be thinking of something else. I might be thinking, maybe the patient's in heart failure, but they screen in positive and the prompt comes up, doctor, should you consider sepsis in this patient? And I say to myself, you're right, I should. I click the button, it takes me right to the evidence-based order set with everything listed there for me.
So again, we're talking about technology really playing a key role in this. Tell me how that helps.
There's even further interventions. Besides the electronic medical record prompt, besides the order set, we used ultrasound at the bedside now. So ultrasound used to be this huge machines, you have to go to radiology. We now have portable, in the pocket of your white coat ultrasounds where we can rapidly at the bedside assess the heart failure, make sure that the body is responding to the treatment we're giving, real time.
So is sepsis the one thing that in the past has really frustrated you when somebody comes into the hospital, ER or wherever they come in, you have they're showing all these symptoms, you don't really know what it is, and by the time you figure it out, it could be too late. So is that kind of the point of why this is so crucial?
Yeah.
Absolutely. Early recognition, the opportunity to treat right away facilitates everything, and communication and working together. This whole collaborative was working with the lab, working with pharmacy, doctors, nurses, information technologists, so building the electronic system to help us so we can not only recognize it early, but treat it early and prevent the downward progression of the disease so patients can go home.
Do you guys want to share a little bit about your outcome measures and your performance, since you're doing such a great job on this? It's reflected not just in your data and your outcomes.
So currently, you know, we look at every single case, we report our cases, and at this point right now, we're actually well above the average for New York State. Every case that goes through, we evaluate, we look at, are there opportunities for improvement? Are we meeting our goals? Cases that we identify opportunities for improvement, we further have a team of experts look at the case, find out where the opportunity lies, and then we address that, whether it's an IT improvement, a provider improvement, nurse improvement, whatever it may be. We look at it as an opportunity for across the board to improve it and not let any opportunity go by. So we're very proud of the successes that we've had.
Sounds like continuous
it is
quality
continuous
improvement.
Boy, you guys have got this covered. Great work and wonderful. Thank you so much for being here today.
Thank you.
So we've had a couple of great examples today of two hospitals that are taking these big steps to always ensure as best they can, that none of those preventable health events happen. How focused do you have to be on that on a daily basis?
It is the number one reason why I come to work every day, is to make sure that we're providing safe, high reliable care. In other words, ensuring consistently the right outcomes happen for our patients. And to make sure, when we showed two examples at St. Francis and St. Catherine's, but these same processes are throughout every CHS facility. So the care that you get at St. Charles is the same that you would get at St. Francis for that disease process, such as sepsis, as an example.
I guess at the end of the day, it's really thinking I have to be able to trust the medical facilities that I'm going to go to. And this is all about building trust as well.
Absolutely. Trust, and I think leveraging the best of technology with the best of people. But if you give me a choice, I'll choose people every time. And we've got some incredible people that work in our facilities that are committed to providing the best care for our patients.
Well, thank you for all that you do. And thank you for watching. It's all the time we have today.
For more information, you can visit www.chsli.org or call 1-855-CHS-4500 for information about any of the Catholic Health Services of Long Island facilities.
Thanks again for joining us. We hope to see you next time on CHS Presents Health Connect.